Hello and welcome. I'm Maria Argos, Associate Dean for Global Health at the University of Illinois, Chicago School of Public Health. On behalf of our organizing committee, I wanted to thank you all for joining us today as we discuss frugal innovations in global health. We have an exciting panel of speakers talking about tools for accessible hearing and vaccine delivery, the role of health activists in healthcare delivery, and preventive measures for reducing neonatal mortality. So without further ado, I would like to introduce Dr. Tracy Pinchman, a member of our organizing committee and a professor and the director of the Global and International Studies program at Loyola University Chicago, who will start our speakers program.
Good morning, everybody, and thank you for being here. So our program today, this is our second annual conference on frugal innovations in global healthcare. We held a similar conference last year and we hope to hold one next year as well. I'd like to acknowledge our conference sponsors and thank all of them for the support that they've given to the organizing committee and to everybody involved in this conference to make sure that it happens. As you know, today we will have 4 speakers, and you probably know already the order of the speakers. Each of our participants will speak for approximately 20 minutes, and then after that there will be time for questions and responses. If you wish to ask a question, please use the Q&A function that you can find in Zoom where it says Q&A. Please type your questions into the Q&A, and then our moderator will get to them during those 10 minutes following each of the presentations. If you're finding the subtitles disturbing, please click on the live transcript icon and hit hide the subtitles, and that will hide them. What is frugal innovation in healthcare? We understand what we're doing here today somewhat broadly as innovations that help lower the cost of delivery of healthcare, doing more with less. Of course, that includes things like affordable, cost-efficient devices, such as low-cost hearing aids. Also, innovative techniques that can move care out of healthcare facilities and into community and home settings. So for example, last year we heard about a mammogram machine that could be brought into villages and outside of healthcare settings. The increased use of diverse health professionals, such as ASHA workers that we're going to hear about today. Anything that improves provider-patient communication, and anything that changes how people seek out and use health services in ways that reduce the costs. Why is frugal innovation in healthcare so important? As we know, there are many factors that affect health: education, employment status, income level, gender, ethnicity. In all countries, whether they're high income or low income, there are wide disparities in the health status of these different kinds of social groups. There are many factors that go into, that go into determining health: economic stability, the neighborhood environment, how walkable something is, for example, education level, the availability of food and healthful food in particular, community safety, all of which we cannot do a whole lot about without changing much larger systems. But when it comes to healthcare providers, and the way that healthcare is delivered, that is something that we can, on an individual level, affect. All of this goes into health and well-being. So by lowering costs, frugal innovations help mitigate disparities in health outcomes and access to healthcare resources around the world. That includes within the United States itself, which is where we, who are hosting the conference, are located. That would include disparities between insured and uninsured, rural and urban, regional differences, and so on. Disparities between nations, and globally disparities between those who can afford services like healthcare concierge services and everybody else. So I'd like to thank everyone who's here today. Thank you to our audience members for attending our seminar today. Thank you to the organizers for putting together an amazing program. Our speakers, of course, we're so happy to have you here and very excited to hear what you have to say. And of course, our incredible moderator, Jerome McDonald, who for many of you needs no introduction. If you live in the Chicago area, you know who Jerome McDonald is. He hosted the program Worldview on WBEZ, Chicago's public radio station, for 25 years. His program Worldview regularly featured global health organizations and social entrepreneurs in its global activism segment. And this, of course, makes him the perfect person to guide us through our conference today. So with no further ado, I'll turn it over to Jerome.
Thank you, Tracy, and I'm really excited to be here again. I really enjoyed last year's conference so much. It made me excited about what's going on in public health and frugal innovations, and it inspired me. It made me think differently about what is possible out there. And I think that's what is so wonderful about the conference and wonderful about doing this kind of work in public health is it's exciting. You get to change people's lives, you get to save people's lives, and doing it in the most efficient way possible with new technology and new ideas. I mean, it's terrific stuff. And I laud all of you for being in this field. And we are going to get started right away and go to a place that maybe a lot of us don't think of as the ethical epicenter of technology. Silicon Valley is where lots of stuff comes from, but I never think of it as like really, does it improve people's, it's kind of scary ethically, but there are people who are bringing ethical considerations to Silicon Valley, and certainly Santa Clara University is one of them. They blend high-tech innovation with a social consciousness grounded in the Jesuit tradition. And Dr. Sylvia Figuera is the director of the Frugal Innovations Hub at Santa Clara University. She leads the mobile lab and advises students working on mobile applications for underserved communities and emerging markets. She is Diane McKenna Professor of Computer Science and Engineering. She's originally from Brazil, received a PhD in computer science from the University of California at San Diego, and has published over 75 papers and established collaborations with both companies in Silicon Valley and social entrepreneurs in the United States and abroad. And we're anxious to have you kick us off. Welcome.
Thank you. Okay, I'm going to share here. Please let me know if this is working.
Looks great.
Okay. Thank you for the introduction. I'm really excited to be here. And actually, I felt really honored to be invited for this, particularly, because I'm a computer science professor, not really a healthcare professional per se. So I'm going to start by telling you how I end up here. So years ago, somebody invited me to a meeting where, they were discussing that technology was really important for social impact. And that was an interesting thought, and that intrigued me. And I started thinking about it and decided, okay, let's take a look at this and start a couple of projects with students doing some computer science projects for social impact. And that grew. Apparently, Santa Clara attracted students that are interested in these kinds of projects. And suddenly I had like 10 projects working on these. And we really fast understood that what we are trying to do with these projects was basically poverty alleviation. That was how people was calling, the kind of projects that we are doing. We had no idea. And we learned also that the way to do this is through empowerment. Charity doesn't go a long way. We need to be working on projects that empower people to get themselves out of poverty. So we kept working on projects, and these projects were growing. But we realized suddenly that the key for this was healthcare. A wise person told me, if you're sick or your kids are sick, there's no way you're going to have motivation to get yourself out of poverty. You need better healthcare. And coincidentally or not, most of my projects were related to healthcare, and I'm going to share some of them today. So we're working on that a lot, and we start to see that, yeah, healthcare does help empowerment, and empowerment does help poverty alleviation. So it looked like we were doing a good thing here, and like Jerome said, even though we're in Silicon Valley, yeah, this is something that the students here do a lot, and it makes us really excited to be a part of this. So suddenly I felt that I qualified to be a speaker here, considering that I have done so many projects in healthcare, even though it's not my specialty. So we're going to talk about frugal innovation, of course, and from an engineering perspective, frugal innovation is about solving problems with less resources. So solving some of these engineering problems is already complicated enough. When you add the fact that you don't have as many resources, things get more complicated. So keep that in mind. For us, it's just, okay, so you have to solve this problem. And yeah, you don't have as many resources as you thought you had. And we focus on humanitarian frugal innovation just because we focus on the needs and context of some impoverished communities. It's not the same as I tell usually my students right here in Silicon Valley. You're not developing for people that live here like you do. So we're considering other needs and other contexts, and you have to take that into account. So again, from an engineering perspective, not only you have less resources, but you have a totally different context. How do you do that? How do you understand what needs to be done? So there's a lot of things that get involved in that. However, one thing is for sure, you cannot do that without technology. Technology is at the heart of what we do in humanitarian frugal innovation. And we've seen that, right? Technology can have a huge impact on global health. And a lot of you here are from global health, and you excuse me, can already see that. But there are some key technologies that have made a big impact lately. And you may have already noticed that. And the first one is solar panels. If you don't have power, there's no technology. So the fact that solar panels, they're not cheap, they're not that cheap actually, but they're way less expensive than they used to be. And now they're inexpensive enough that you can actually do projects with them and have these projects in some communities that don't have a lot of resources. Remember, less resources is an important thing here. So solar panels is the first key technology that we basically make use of to do what we do. The second one is mobile technology. Basically, mobile devices, smartphones, cellular phones for that matter, and tablets, they're becoming less and less expensive and basically widespread. And having that as a tool has enabled us to do a lot of interesting things, and especially for global health. And I'm going to give you some examples of that as well. And the third one is sensors. Sensors are becoming really inexpensive, and they are able to do lots of interesting things. And we have done a lot of projects with them as well. So I have worked over 60 projects over 10 years, more, I think. And in the School of Engineering at Santa Clara University, every year, 1/3 at least of the projects that the seniors actually work on are for social impact. So we have a huge number of projects. If you go to our website, you can see that. Of course, I only have like 15 minutes, so I'm going to give you some examples of some of projects using this technology just to give you an idea of what we are doing. So power is, of course, crucial, as I said, and without power, you cannot do much. And We Care Solar is an interesting organization that actually showed us really early. These people, they were working in some impoverished areas, and they are really frustrated because sometimes people would die at this clinic with a problem that was actually easy to solve, but there was no power for the doctors to do something about that. So they created this organization to sell these suitcase solar panels. And they sold a lot of those. And basically, they help to save lives this way, just by bringing power to these clinics. So important power is. And of course, we can use power in other devices as well. And this is another example of a project that I really like. And this was done in mechanical engineering and computer science and engineering. It's basically a fridge. When they did that, I wasn't involved. They did that for an organization that was complaining that this is a place where there's not a lot of food, but because they didn't have a fridge, food was going bad and they had to throw food away, which is an ironic situation here. So they wanted a fridge, but power is a problem. And of course, resources, not a lot of money. So the students actually designed this refrigerating system for them, solar powered, And interesting enough is the fact that, okay, we did this because of food. However, fridges are also super important for medicines and vaccines. And that was pretty clear during the pandemic, right? So the vaccines actually really required to be kept in fridges, and some of them are really low temperature anyway. So without power, there's no way you can do that. So solar panels actually enabled you to actually bring these kinds of devices to some places that wouldn't have them otherwise. So the second technology that I talked about is basically mobile, and this is my area. That's something that I do a lot. And mobile technology basically providing access to several things: information, services, and inexpensive devices. And this is affecting different areas. It's affecting healthcare, education, banking, agriculture, transportation. I know this is all about healthcare, so I'm going to focus on that here. But I have done applications for all kinds of different areas as well. In healthcare, we have already seen that change, right? I mean, the mobile devices are enabling some very expensive devices to become a lot cheaper by basically using the mobile device as an interface. The ultrasound is an example of that, right? The sensor is the same, but instead of having this big device that was really expensive, now you can actually see the result on a mobile device, which makes it a lot less expensive. The same with AKG on the other picture. And even a microscope. When I started doing this about 12 years ago, this lens to make your phone into a microscope was basically research done at UCLA in Berkeley. But now you can buy those at Amazon, and they're not even that expensive. So you can turn your phone into a microscope, which is really useful for diagnostics of some disease. So these devices are basically widespread. They are all over the place, and they are enabling us to do a lot of that. So a lot of my students actually work on applications to help use these devices in a better way. We worked on a long time ago, one project that actually relates to that, and this was about audiometry. So if you have a hearing problem, you go to a doctor, and there is this device that generates sounds at different frequencies, and you have a headphone, and you click yes or no if you can hear them or not. Of course, this device is expensive and requires a technician to actually do the exam and a doctor to basically process the data. So what the students did is they did a lot of research, understood how the device worked, and this device is expensive. So they actually were able to do the whole functionality of the device on a smartphone, which was really interesting. So the phone generates all the sounds, and you press yes or no if you can hear it. And at the end, the phone does all the calculation and actually show you your hearing range, which is really important, just like the other devices, because now you can actually do that in impoverished areas, and you don't require the big device anymore. Also, because if you have that app, you can actually do it yourself before even going to a doctor, because sometimes doctors are not available in some places. So you can do a pre-screening to see if you have a problem or not before you make the effort to go to see a doctor. So basically, it's a good thing for pre-screening. The other area that we have been working on is using these devices for information. So we work with an organization, Rose Academies. They operate in Uganda. And after working in some of these communities for a while, they understood that people lack information for some important things. And this is affecting their life a lot. So we started working on some apps to educate people on some important issues. So the first app was Head Help, and it was supposed to educate young girls on menstruation so that they wouldn't drop out of school. So basically educate them what's happening to them and to their friends, so that they don't panic and they stay in school, because this is normal, it's not a big deal. Another one is Mrna Thrive, and it's supposed to teach people about infant care. And the whole idea here is that sometimes the parents don't know what to do when they have little babies. They don't have enough information, or they're away from their parents, so they don't have people to ask. And sometimes babies die, a lot of them in the first month, because of lack of information. I always joke with my students, telling them, when I had a baby, I had no idea what to do either. My parents were in another country, but the hospital gave me a booklet, and that was my Bible. I would, bring this everywhere, and whatever happens to the baby, the booklet was there. These booklets are not available. These people sometimes don't even go to a hospital to have the baby in the first place. So having information actually on how to take care of babies is really important, because a lot of babies die in the first month because of lack of that kind of information. And the third one that we have developed is Obulamuids, and it's about nutrition. Again, lack of resources, and sometimes lack of information on what to eat leads to lots of problems with malnutrition and diabetes, which kind of, ironic situation here. So teaching people how to eat better, particularly now because of the long droughts, the foods that people can, the farming are changing, and the kinds of food that actually they have available is changing. So understanding what they have to do to actually keep in the nutrition is super important. Okay, so the last technology that I'm going to mention is sensors, like I said before, and sensors are becoming super inexpensive. So, and because they're inexpensive now, they're enabling lots of interesting solutions for different areas in healthcare, and which we are interested here. Also citizen empowerment, which is also important here, and I'm going to give an example, but also for other areas, farming, disaster relief, and many, many others. So we are using sensors all over the place, even in disposable things, which is really intriguing. So the example on the picture is Neopanda, and this was an organization that was founded by 2 women, and one of them was actually a bioengineer at Santa Clara University before she created Neopanda. And the idea is that they went to these hospitals in some places where there were so many babies and not enough nurses. So once in a while a baby would die just because the baby was not okay, but nobody could see it because there's so many of them. So they realized that they could put some sensors on the babies and connect to dashboard, and then the people would actually know if there's something wrong. So they went through several iterations, and this is the final one they have now. It checks 4 different signs on the baby, and the sensors are connected to a dashboard, and if something goes wrong, there's an alarm or something goes red, and they see and they go help the baby. So this is actually making a big impact. And we're going to talk about some projects, a couple of projects done at Santa Clara University. The first one is Nuke Guard, and this is about breast milk. So breast milk is super important for babies. However, not everybody has breast milk, right? So there are breast milk banks. They do exist, but they're expensive. So some people donate breast milk. The problem with that is the fact that the breast milk comes from a place that you don't know. So what if it's contaminated? And this is a big problem, turns out. So these students actually in bioengineering and electrical engineering came up with this paper sensor that you drop the milk on it, and it changes colors depending on contamination of E. coli. Depending on how blue the color is, it's more or less contaminated, as you can see in the picture. And then they also developed an app that you can actually take a picture of the blue and it tell you how contaminated the milk is and if it's okay or not to actually give it to the baby. So this is what I mean by citizen empowerment. You can check your own milk before, not your own milk, but you got milk from this donation center. You can check the milk before giving to the baby, which gives you some confidence that okay, the baby is going to be okay. I am actually the one checking the milk, not just somebody else. So I can actually trust that. Along with this idea, some years ago, we developed this other tool called Aquasift. And this is about contaminated water, which is a problem everywhere, which is embarrassing considering we're in the 21st century, but contaminated water is a big problem. And so we created this tool to check the water, again, to empower the citizens. So there is a sensor, you put it in the water, and then it generates a current that goes into this device that was developed by the electrical engineers, and then goes into a phone that will tell you on the spot if the water is okay to drink or not. So the idea is that you are able to check the water yourself, because if you don't have something like that, you put the water in a bottle, you send to some kind of lab, and eventually receive the results. So, but this is not always easy to do, so you end up drinking the water that is contaminated, which happens a lot. So they did several sensors for detecting different kinds of things. Arsenic was the first one, but they did other substances as well. And this is a project that was done, over several iterations with lots of students actually working on it. Before I finish and I answer questions, I'd just like to thank lots of people who have funded our projects. Actually, our dean is usually our main partner here. We have had several deans over the years, but they're always super, super supportive of everything we do. And companies in Silicon Valley and IEEE has actually helped us a lot. So we have been really lucky to partnering with lots of different companies and people actually. Okay, so this is my contact information. Feel free to email me or check us our website. There's lots and lots of projects there. We're always, happy to share our experiences, and I'll be glad to answer any questions.
All right, that was really interesting, and I'm amazed at the kind of breadth of everything you were doing. I wanted to ask a question. Is it, are you kind of doing coding for social good? Is that what's going on here, Sylvia? Is that, if I summed it up?
Oh, well, coding is part of it, right? Because I am in computer science and engineering, so my students do code for that. But we have projects across the board. So the mechanical engineers do their thing, the electrical engineers do their thing, and the bioengineers do their own thing. But so coding for good is part of what we do, and that would be my students because I am in the computer science and engineering department. So we do lots of apps, lots of apps for free. That's how I usually tell people.
We've got a few questions here. Are the apps accurate? Like, how do you really know if the audio apps are they standardized? How do you work something like that?
There's a long story for all of that. So it depends on the project, right? Some projects are simpler to do and to check. Some are more complicated, and some of them we publish papers about. They are proof of concept. We never created a company to do them. If you actually are gonna create a company and get that in the market, you're gonna have to go through another level of checking and determining if this is actually okay. However, yeah, my students, they do a lot of that, but we haven't really created companies on it. Some of them graduate and they go and do that, but it's not part of my job. So it depends. So the bioengineers, when they are doing these sensors for checking water and things like that, there's a lot of research and a lot of experiments to make sure that it's actually accurate. So it's a lot of testing, and I've watched that, and I'm not a bioengineer, so I'm not gonna go into that too much, but there's a lot of tests that they do to actually make sure that it is accurate. So they have guidelines for that.
How do you make sure that the things you're developing, if they're not commercialized, how do you prevent them from getting commercialized? I mean, do you want to prevent them from getting commercialized, or how do the innovations meet a broader section of people?
There's different paths here. So there are projects they are going to be a proof of concept, just like research at a university, right? You're going to publish a paper and you're going to tell people we did this and it works, and and there's no way to prevent, and we don't want this. We are just sharing knowledge. That's what universities do, a lot of them, for some of the things we do. But there are other things that are very specific. So we work with specific clients and specific organizations that work in specific communities, and they come to us with a wish list, and we develop something for them. So we donate. So a lot of the code we do, a lot of the apps we do, basically are donated to the end user to do what was meant to do, and they're very specific. So even if they get commercialized, we are fine with that. We are doing this to help people, not to make money out of it anyway. So we donate a lot of apps to specific organizations that ask for that.
And then there's a question about app maintenance and who maintains the apps after they're deployed, if they need updating, if mine are constantly getting updated.
Yeah, that's the beauty of having the Frugal Innovation Hub. So we actually hire grad students that keep doing that. So sometimes whoever got the app comes back to us and can we add a new feature, or can we change this? So we hire grad students to actually do that. So we keep watching those as well.
There's a question about the availability of smartphones. How available do you find that they are? Is there an assumption of availability about it? Is it do people know how to test water, even if sensors are available? Is this something that is just I don't know, it seems too complicated for the end user sometimes?
Well, that's part of the concept of frugal innovation, right? Things need to be simple. It's one of the things in the guidelines. So the apps that we develop, depending on where it's going, the interface is going to be simple. It's going to be tested and at the place where it's supposed to be used. So we work a lot into this interface to make sure the interface is actually good for the population that we are targeting. So we developed lots of things, for example, for homeless people here in the Bay Area, and the interface needed to be simple. We couldn't have a lot of buttons everywhere. So also for things like disaster, you don't want things that are complicated because you are in panic and you don't want to have to deal with a complicated interface. So there is a lot of thought that goes into the designing for this. The other question about smartphones is different today. So the number of smartphones around the world is growing and growing and growing. But we have developed, we don't only develop things for smartphones, we have developed things for feature phones. Feature phones is a little simpler than a smartphone, but still we can do an app for that and can have some of the functionalities. It's just not as smart, let's put it that way, or sophisticated. But we have done things for that too. But even smartphones, this market is really growing and they're cheaper in other places. They're just not as sophisticated as some of the ones we use, but they do a lot and they are actually way more widespread than we realize. But it's not even necessary to have one. We can use a simpler phone as well, depending on the situation.
Lastly, I'd like you to remark on what it's like there in Silicon Valley and what your collaborations are like with some of the larger entities there. I mean, you mentioned Cisco Systems you have relationships with. How receptive are they to what you're doing? I can understand students being enthusiastic about this. Is the universe there when you tell them what you're doing? Do they want to hear this, or are they kind of hooked up commercially that that it's just a little tiny carve out generous thing that they do?
Well, again, this is a longer story, but a lot of the companies here do have some funding for things for doing good. Let's put it this way, things, right? I mean, and it's a lot of them do, and they, depending on who you're talking to and depending on the company, they will donate for different reasons. So Cisco helped us a lot with some applications that we did for homeless people, and they did a lot of funding for that. Also, I forgot to put that in there, but this is a long time ago anyways, but Google donated a huge number of smartphones for homeless people as well, because they realized that cellular phone enables people to empower them to get out of the street. And this was proved, and they donated a lot of phones so that we could do this project and have a lot of homeless people use these phones to get help and things like that. So they operate they donate for different specific things. Like right now, Xilinx is helping us because they believe that these projects attract women to engineering, and they think this is important to have more women in engineering, and it's true. A lot of my projects, there are a lot of women, the female students actually interested in working in them, and it is what it is. It's not that I planned like that, it just happened. So, and Xilinx believe this is a thing, so they actually donating because they think these projects actually attract women. So the companies will donate depending on the situation and the project, but they have been really generous over the years.
Well, it's really interesting hearing about your work. I'm glad young people involved in computer science are really interested in frugal innovation, and I salute you for doing it there, right there in Silicon Valley. Thanks a lot, Dr. Sylvia Figuera from Santa Clara University and the Frugal Innovation Hub. Great work there.
Thank you. Thanks for having me.
We're going to swing over now and talk with another innovator, Professor Saad Bhamla. He's an assistant professor of molecular biology at Georgia Tech, and he's a self-proclaimed tinkerer, and his Bhamla lab is a trove of discoveries and inventions that span biology, physics, and engineering. And his current projects include studying the hydrodynamics of insect urine and worm blob locomotion. And for our purposes, an ultra low cost devices for global health like hearing aids. And his works appeared in the New York Times, The Economist, CNN, Wired. He's gotten a lot of press. And his award-winning innovations include a 20-cent paper centrifuge, a 23-cent electroporator, and the two we'll be hearing about today, the hearing aid and the DNA vaccine delivery. And it is great to have you with us, Saad Bamla.
Thank you so much. Can you confirm you are able to see the slides? And okay, and you can hear me, I imagine. Okay, great. Thank you for the opportunity to be here, and appreciate the introduction. Hopefully, I'll not talk about worm blobs or insects peeing, but I'll tell you a little bit about the frugal science work that goes in my lab. And we have we have a few different problems and ideas we're working on, but for this brief conversation today, I'll tell you a little bit about our efforts in thinking about equity and accessibility for molecular nucleic acid vaccine delivery, as well as trying to address the gap in bringing affordable hearing aids from an LMIC context, so low and middle income countries context. I think for this audience, this doesn't need to be said, but just as a reminder, I grew up in India, and this is something that drives my work and my team. We think about the planet as a finite resource where we share with billions of others, and not all of them have access to the income levels to spend on healthcare, and billions, including children, will live on a very minimal budget, if you think about it in dollars. And so that, for me, it really drives us to think as engineers, how do we build access to hardware? Because I'm at Georgia Tech in Atlanta, USA, and what I might look at a hospital for healthcare or research lab or undergraduate education or high school education might be completely different in some of the places where we might do a field work, where an open field might be a hospital, hut maybe where somebody might do research on mosquitoes and transmission of disease, and just, empty rooms may serve as education, pedagogical institutions. And so what I'm driven by is thinking about how do we really bring hardware that addresses challenges across science, medicine, synthetic biology. And I'll show you a couple of examples that hopefully let you think about really how do we reinvent the tools that we use in our fancy labs, but that empower us to do diagnostics education under a tree. And even harsh resource constrained environments, we've done synthetic biology and bringing molecular tools to deep in the Amazon rainforest. And those challenges that exist in these harsh, extremely biodiverse places are the same for education and resource constrained environments. And I think this is something being in Georgia for the last 5 years where I run my lab has started to impart onto me that this tight coupling between both local and global. And I think with the pandemic, I don't need to say this, really global is local, and also this tight coupling between education and global health applications kind of go hand in hand, as we heard in the previous speaker, which I think raised really important and inspiring aspects of how we can channel the next generation of scientists to address some of these challenges, whether they're in my backyard in Georgia or Alabama, but also in Malawi or India or Iraq, wherever they might be. Okay, so with this, I want to tell you the story about the hearing aid, and it's the inspiration for this starts when I was doing my undergraduate in India, and I felt pretty confident. I was going to one of the IITs, and I felt I could, do something with the world. And I just got on my first phone, and I had realized that my grandmother had, as people grow older, some of you who are listening will also realize that you lose hearing in the higher frequency, and that was the case for my grandmother. And here I am, this young engineer coming up in the world, and I thought to myself, oh, if I can buy a phone, as a treat, as a gesture to my grandparents, I should buy a hearing aid. And this is in Mumbai more than 10 years ago. And it was very sobering when I went to buy a hearing aid to realize it cost, more than 10 times the cost of the phone I had. And this stuck in me because I realized I wanted to kind of help my even grandparents. And some of you, I've heard stories over the years with my hearing aid that we built, that many of the people actually want to do something for their own family members, and they quickly realize how expensive this is. And just to share some numbers, hearing loss is a global issue, and the World Health Report on hearing really reveals the severity and the access. And this goes beyond, obviously, hearing aids, right? Hearing aids is just one part of it. Many countries, often now we understand, don't even have any at the governmental level and regulatory level, anything to do with hearing assistive technology training. And so it's a huge challenge. But the point I want to focus on is that really hearing aids are manufactured by basically 5 conglomerates, and they don't even address the World Health Report. These are their claims. They don't even address 10% of the global need for hearing aids. And you may know somebody who, if you're in the US or Europe and Canada, you might know people who want hearing aids, whether you're in Chicago, that can't afford them. And this has to do not just with the hearing aids, but also the medical care system. But in low and middle income countries where hearing aids really are needed, it can be as low as 1 to 15%. And I want to distinguish that hearing aids is a very generic term, off the counter, and I'll comment on this, are also known as personal sound amplification devices. You can go on Amazon.com and try to buy one. And I'll kind of give you a caveat for when we started the research, how there are caveats with trying to understand what you can buy off the shelf. Just to reinforce this, that although this is a y-axis is the cost of the hearing aids as a function of time over decades, and really electronics you can buy now, cheap electronics, they have reduced, ICs have reduced in cost, but hearing aid cost has only gone up. And it's really not about the technology, it's really about what we're willing to pay, and the manufacturers that control this should become very, very clear. And that's why every new iPhone, it's the same thing. It gets more and more expensive. So any case, I want to also highlight when this was in 2015, the President's Council wrote a report to really challenge the FDA and encourage the FDA to think about over-the-counter hearing aids, similar to how, as we grow older, we need reading glasses. It's the same biological problem, right? We need hearing for elderly people. And really, the PCOS in this report in 2015 highlighted that a hearing aid in the US on average costs about $2,000 to $3,000. And if you need, we all have 2 years, and if you need 2 hearing aids, that's about the cost of a used car. And really, that's a major obstacle. And so this is a local and global problem. Here's something I wanted to highlight. This is a very interesting paper by Bradley McPherson, who's one of our advisors based out of Hong Kong. He's also written the WHO guide for preferred profile for hearing aid for low and middle income countries. I will highlight something that this paper, when we are talking about designing. And so before you start a design, you really do need finding and talk to experts. And in this, I'm highlighting that he's saying that about OTC devices that you might find in markets in Peru, in India, in China, in Hong Kong, in Taiwan, in Malawi. And he's saying these OTC over-the-counter devices, they had done a study about all these you could buy for $10 or $20 or $100. And they had done it a decade earlier, and they're just following up. So the title is Over-the-Counter Hearing Aids, A Lost Decade for Change. So they buy 60 of these that were particularly targeted for elderly people, including, for example, a person like me who want to buy a hearing aid for my grandmother. Presbycusis is this age-related hearing loss, the equivalent of us needing reading glasses as we grow older. And he says they do this, and they find that these off-the-counter they have poor electroacoustic performances, ineffective volume control, high input noise, and irregular frequency noise. Essentially, in some cases, they actually perform negatively and create more issues. And this is really discouraging to read this, because they had done this 10 years ago and they follow up 10 years ago. He's saying nothing has changed in about 20 years, and this was in 2015. And in our recent conversation, we're still at the same issue, that hearing aids over the counter, really low quality control regulatory pathway. This makes it a very, very murky area. Okay, So long story short, we decided to try to solve this problem by taking a more frugal engineering and open hardware approach. And this work was led by Soham, who actually, when we I met him in the first week I started my lab, and he was born with hearing illness, hearing impairment, and so he needed hearing aids for his life. So the point I'm trying to make is that this wasn't just a professional thing, this is a personal mission for us. And we challenged ourselves over 3 years to build a hearing aid, who Soham, by the way, is now off to doing his PhD at Stanford. But he was an undergraduate when we were working, and we built this Locate, a low-cost hearing aid made by off-shelf electronics. We published this in PLOS One, and our 3 principles that we focused on was cost, safety, and efficacy. And so if you look at the parts that we use, it costs about 98 cents if you buy them for 10,000 units of McMaster and Alibaba and so on and forth, and you can, we're not including manufacturing and assembly costs here. And really, if you ask me, what was it that allowed us to really hone in and reduce the cost in addition to the mass manufacturing electronics? What we are leveraging is this remarkable thing about biology, that it fails really in a spectacularly repeatable fashion. What I'm showing you here is the acoustic profile of thousands of people across the globe. And it shows you different ages, right and left ear, going from all the way from 60-year-olds to 80-year-olds. And the x-axis is frequency. All it's showing you is that these curves kind of lie on top of each other, suggesting that we are losing this hearing in the high frequency. But what I see here is that if I were to design a hearing aid, essentially I need to focus on amplifying above 1,000 hertz, and it kind of gives me the recipe. Really, this is how we build reading glasses. That's why you can go to a CVS and pick up a reading glass, and you wear it and you're like, oh, this is not good. You've just put on another one, because the failure is so similar, you don't need to go to an optometrist. I hope that makes sense. So that's the kind of approach we're taking for hearing. There's caveats here, but this is kind of a high level point. And so long story short, we teamed up with audiologists, we built this device, did the gold standard testing, which is using this expensive box, audiometric box. Here's the Locate. We do these speech map tests, which really, instead of just playing tones, you're actually testing speeches in over 60 languages. And this purple curve is showing the hearing aid performance amplifying above the 1,000 hertz, all the way up to 8,000 hertz, which is really in the needed. And it's showing that it should give you a good performance. And we did additional tests with these mannequins where we're trying to mimic the ear canal, and really all of these small things that make hearing so complex a problem. And I've learned a lot and started to appreciate the complex biology and the biophysics that go into really addressing this challenge. So this is so far so good. And this is just kind of a summary of what this Locate can do. In this table, I'm showing you 2 columns, which is the WHO recommendation and the National Institute recommendations for hearing aids. And we kind of meet all of these for OSP at 90 degrees, average OSP gain, harmonic distribution at 70 dB, all of these technical things, except one, where WHO and the National Institute recommend essentially equivalent input noise. This is the electronic hum on these electronics that should be less than 32 dB SPL, and we're about at 40. We are optimistic that we can kind of address this, and we also have other hypotheses, but we don't think this is a deal breaker. And if you will, at a price point of $1, this might be one of the trade-offs that we have to deal with. But essentially, this is one point that we're still working on. Okay. So with this, we publish this and we put these YouTube videos on how to manufacture. I'm very proud to say that, we got tens of thousands of views on this, which is remarkable as a scientist. You publish papers and then you hope that people would watch this and, read your papers. And we put all these tests about dropping this thing, putting it in water, because we're trying to match the environments of different humid environments. And this is the joy that I get to share, that we got so many folks rebuilding this. These are DIY retired engineers, enthusiasts from Senegal, to Malawi. I'm showing you a couple of these who rebuild them very creatively. And the point I want you to take here is that our strategy of both being open, but also using mass manufactured electronics really enables other people to do it. And if you've ever been to a low and middle income country, some of these are actually using these cell phone repair shops that enable them to fabricate these things. And it's just remarkable how innovative and people are. I'll share you a vignette of a few emails. This is a person who's telling me that, I made the picture, and he's going to a school and telling them to 3D print something. it's working nicely. This is a gentleman who tells me they actually found an issue in our schematic, which is so amazing to me that, you know, as a scientist, I write papers and hope people read it. And this person's gone to our schematic and actually told us that we had a typo of using, you know, a 10K resistor. And he's 62 years old, and these are all small N. They're telling us that they are able to hear, and he's struggling to hear. But sorry, I want to say one last point here, that the next step over here is that we are doing pilot testing in South Africa and Malawi with audiologists. Things have been delayed due to COVID, but really we're trying to do this in a more systematic and controlled fashion. And the hope is to do a spin out. And I'll mention this again in the end of how do we translate this technology to the real world. And I'll comment on that again. So that's story number one. Okay, let me have a sip of water and then transition to story number two. Okay, so this is ePatch, and really, I'm amazed by mRNA and DNA vaccines and how really they're transformative power. But I'm also cognizant that we should be able to build. Let me help illustrate kind of the challenges of this and how we can build this technology to help deliver this. So this is the ePatch on the left-hand side compared to a needle, just showing you visually what its size and form factor is. And the point is that, you know, infectious diseases, I think nobody wants to hear this anymore, but unfortunately they're spreading faster than, you know, we can develop vaccines. And just a quick snapshot just for COVID, what's shown us over the last 2 years is that, you know, we've had more than 5 million deaths, and it's become clear that it's definitely a larger number. But even now, there are about 4 billion people who are unvaccinated. And I want to emphasize that obviously what we hear in the US is a lot of hesitancy about different things and misinformation, but for huge amount, billions of people across the world, this is not due to hesitancy. It's due to lack of access of these, you know, remarkable, astounding technologies that are just not accessible. And there are barriers to bringing these, you know, technologies to them. And the other point, I think it's clear to this audience that COVID is just the beginning. And mRNA vaccines are really a powerful tool now in our arsenal, where this shows that they went from 40 days to the clinic to in less than a year to emergency use authorization. And this, for the vaccine community, is just remarkable, right? Greater than 90% efficacy. This mRNA is just a story of success for at least part of the world. So I want to emphasize that when most of you who potentially got this mRNA, whether it's the Moderna or the Pfizer BioNTech shot, really what you've gotten is a complex mixture of mRNA molecules, which are these tiny nucleic acids. But to get them not just inside your skin, which the needle does, you have to actually get this inside the cells in your body. So let me repeat this because this is very, very important. Unlike traditional vaccines, here what we're doing is using the body as a living factory and just giving it the computer code, which is mRNA, and then let the body develop these, you know, proteins and antigens to fight this virus. So then this information, if you just put it inside the skin with just an injection or inside the muscle, it's not enough. It needs to go inside the cell. So there are two barriers that this mRNA needs to cross. So what helps us is these LNPs, which are lipid nanoparticles. So this is essentially, if you think of mRNA as the Batman, LNP is not the Robin, it's actually a Batman as well. And these two, Batman and Batman problem in drug delivery, help us get this information inside the cell where the cell's nucleus can take this up and make it. But this is also the Achilles heel or the bottleneck, because these LNPs are particularly associated with the reactogenicity. That's why you had to take a day off or plan, and we're worried about giving vaccines to less than 5-year-old, and you know, people went into anaphylactic shocks, but they also require these high cold chain requirements. Also for manufacturers, this is a huge burden because you use all these microfluidics to make these LNPs. So there's a whole story here, but I think if you take one thing away, just recognize that mRNA vaccines and LNPs is a huge bottleneck, and we all recall that's why, from a global health perspective, distributing and bringing this to every last mile and village is an issue. It's not a trivial problem to solve. So in summary, really, I'm focusing, mRNAs are great, but LNPs that we need them to get inside the cell are expensive and complex, not for just COVID, but also in the future for these future pandemics. And if we could get mRNA vaccines without LNPs, that would just be remarkable. That's our hypothesis. And there is a technology that allows you to do it, and that's electroporation. So essentially, you can apply a brief electric pulse, and you can open up the cell wall and get this information, mRNA or DNA inside. and you don't have to use this chemical formulation. So here's the distinguishing thing, just to re-emphasize. LNPs are a chemical formulation, but electroporation is a physical pulse. So instead of giving this massive glitter bomb that goes and ends up who knows where in the livers and stuff, we don't know, we're hypothesizing that this electroporation, which has a long history of notable study for DNA vaccine, if we could use that, that may solve our problem. But the reason it hasn't been successful is because how complex, how massive these things are, and they're extremely expensive. So we do have a technology, but that's actually a bottleneck because it doesn't scale from a global health perspective. And I'll share a quote with you that one of the DoD colleagues, as they were exploring this to bring back these remarkable vaccines out to the rest of the world, and they said that we don't need a device that looks between a sonicator and a stun gun. It's not the kind of PR we want because, again, hesitancy. So I want to tell you about how we solve this electroporator problem and what it opens up. So this is work was led by Gaurav, and actually the story started before the pandemic in 2018, where he wanted to do synthetic biology. He had this idea about CRISPR, and this is where high school education and synthetic biology kind of merge with vaccine delivery, because he needed an electroporator. And we realized that something that all of us use at home or on 4th of July barbecue, just a lighter, actually has a piezoelectric crystal, which is ridiculously cheap, right? You can buy a lighter in any street, whether you're in Pakistan or Afghanistan, you can buy lighters, and we actually check. These are really cheap, robust things. And if you probably heard that, and I'll play this video on loop. You can see the spark. So every time you click a lighter, you're actually generating an electricity without using any power sources. It's just a mechanical way to generate. And we showed back in 2020, but we did this in 2018, that you could use this to do genetic transformations of E. coli, and we devised this thing called an electropen. And so you see the data on the right-hand side with E. coli, and we're very happy with it, and we're sharing this with kids all around to do synthetic biology. And I was very proud of myself that, we solved this, opened up enabling students to do synthetic biology. But just slightly before the pandemic, we had this crazy idea of not just doing E. coli, but what if we could actually bring this technology to mammalian systems and think about DNA and mRNA vaccine delivery. So I went across campus to a colleague who studies microneedles, this is Mark Prousnes, and told him, hey, we should combine my technology with yours. And so that's, after some hesitancy about this crazy idea, he kind of he agreed to this. And so we built this EPAT. So it's a mash of two technologies, microneedles shown in panel D and F. These are really, really tiny needles. And in our case, they're made out of metallic electrodes. So they act as really the field strength that we need. And then we put our barbecue lighter. And just as a visual, this is what's happening on the bottom left. You put your DNA and mRNA inside your skin, and then you pulse it with this lighter, and there you get the DNA or mRNA inside the cell to actually do the miraculous job of, the cell can use it up. So we need to get both of these steps done. Inject it inside your arm, but then you need to pulse it to get it inside the cell. If you don't get it inside the cell, really the vaccine doesn't work. So emphasizing again, electroporation is key, and we don't need the LNPs here. We showed that really these microneedles and this barbecue electroporator give us this amazing field strength. So that's volts per centimeter on the order of 3,000. Essentially what this is saying is that this clever innovation of using microneedles, by making them very, very tightly spaced, we get the necessary field strength to reversibly create these spores in our cells so that they can take up the DNA and mRNA. And so this already is remarkable because, again, remember, when we started out, this is a barbecue lighter. So the fact that we can actually do this is just incredible, and we can generate these fields. We did this in mice. This is in my skin, showing that in fact with GFP the response is localized to the epidermis, and in vaccine delivery it's very well known that the skin is a very good target for vaccine delivery instead of just the muscles. And we are showing that with our electroporation, we can indeed get GFP inside the cells, and they glow up and they go into the right place, and it's working quite well. And this is actually quite safe as well. So this shows us that these microneedles really, within 3 hours, these tiny pores have closed up and your skin is healed, and all the inflammatory markers are gone when we check about 12 hours later. Again, the emphasis here is that this pulse that we apply from the lighter is so gentle, just like a mild twitch, and it's really, really safe. And this is again in rats. And so then the next step was a crazy ask, right? Like, does it work? this is where we go to our Emory collaborators. And I didn't know this at that time, but when we did a media release on this work, he commented to the reporters that he didn't even believe it would work, because he was very concerned about this janky contraption we'd made with barbecue lighters and microneedles, but at least he was open-minded enough to try. And here we're doing essentially, I believe this is in rats, and we're doing basically a vaccination study for SARS-CoV-2 DNA vaccine. And the takeaway here on this plot is that compared to a traditional intramuscular vaccine, so that's in the olive green, IM_100G, our intradermal with the e-patch, you just need 10 micrograms. And this is important because you get a 10-fold dose sparing. And by the way, the intramuscular vaccine is basically what all of you got when you got your Pfizer and Moderna shot. And we are proposing you can do it intradermally, which is definitely less painful because you don't have to inject in a muscle. And again, this is following the mice for 4 to 8 weeks, where we give both of the shots and show indeed that you boost the immunity and you can neutralize against the SARS-CoV-2 pseudovirus all the way up to 90%. So that's showing that this vaccine in mice at least works. And this e-patch works. So essentially the summary is this: we built this amazing technology. It's this e-patch. You can deliver mRNA without this complex lipid nanoparticles, which require this cold chain and manufacturing and chemical. It's just a physical pulse, zap, and you're done. And we're at least the data convinces us that it's safe, affordable, and scalable. And to me, this speaks to this frugal approach, right? Because lighters are made everywhere. So it's inexpensive, you fit in your pocket, it's disposable, no batteries required. And, we make lighters and almost like a billion scale, all of us still need lighters. So for us, thinking about manufacturing, and these microneedles are very cheap to make, they're just sheet metal, is important if we want to scale this technology. And again, training users to use this at last mile health workers is also very encouraging. We wrote up this paper late last year in PNAS, and I think we're trying to now do a spin out. So I want to pause over here and kind of summarize what I've told you. I've told you about 2 devices, the e-patch and the locate.
Yeah, and we're about out of time. We're a little pinched on time, but that's really.
Do I have 1 minute to say 2 things? And then, okay. We also wrote a paper on this frugal science, and really it's an invitation, and we show case studies from X-rays to microfluidics. I want to end on 2 thoughts, and this kind of resonates with some of the questions you're going to ask me about translation. And this one is when I was doing in Madagascar my work on paper centrifuges. I showed this, and we were doing malaria diagnostics, and the community health worker over there, she laughed at me and she said, "This is what you built at Stanford." This is when I was. But the next day she came building her own device with a pickle jar and threads. And the point is, as I looked at it, she said, "I don't need you to build this. I could have done it." And I realized there's an explicit goal over here as I'm building technology, but the other goal is that it challenge everybody to think about that you could build this. And indeed, that's trying to empower people to become problem solvers. And the second story here is when I asked to build this first device of low cost, I went to Capita Foundation because it's very hard in these things to raise money. And I had to go back again to tell him I built the technology, but really to create the company, to scale this and to translate this, it's really hard. And I hate to ask you again for money. These are founders. And he said something very interesting. He said, the difficult things we can do right away, but the impossible takes a little longer. I just want to leave you with this, that really, I think I can do the engineering, but translating and building the community and bringing this to the real world is the next challenge that we're thinking about. Okay, with that, I'll pause.
I'll just ask a couple of quick questions here before we move on to the next speaker. One of the questions in the chat is really about how do you think frugal technology can be distributed to, say, remote, non-accessible communities with this hearing aid? Can private businesses take this up and not face competitors? Who is going to have access to the open source plans? I mean, are you expecting people to make it themselves, or how do you see that going with the hearing aid?
So currently the hearing aid is just open, and as I showed you, people are using it, building and improving on it. We realize that that's just not fast enough and that doesn't scale. So we're doing it in 2 parts. We're doing our clinical work to really be robust and critical and rigorous in our data collection. But the second part is we are working with the Disability Impact Fund, who are helping us kind of figure out how to sustainably manufacture and create a nonprofit venture to bring this out in, specifically, we're focusing on Malawi. as our test case. So that's the impossible part of figuring out how to create a venture that actually does it, because it's easy for me to build these technologies and write papers, but to build to translate it is really the hardest part that I'm figuring out now.
And what about the needle? I mean, it seems like if the needle really works, you would have people falling all over themselves to fund it and distribute it. It's how
I wish that was reality. We have been pitching it left and right, and we also got our grants ejected from NIH. You'd be surprised. You'd be surprised how hard it is to raise funding for frugal science stuff. I wish it was easy.
And
I wish VCs were lining up to help us. Yeah.
What's the fear about that? I mean, are drug companies, would they say, well, this would put us out of business? We have all these big labs and this is what we do. And we manufacture this stuff and we don't want to stop.
It's the same challenge, right? It's why insulin prices are high, insulin pumps are expensive. It's the same thing why hearing aids are so expensive. Really, I don't know what to tell you. Like, does that make sense? It's just, yeah. I can make things cheaper, really. All technologies are not that expensive. It's really, that's not the problem. It's really, we have to find sustainable ways to take these things and figure out a way to, and that's, I'm genuinely struggling with this, of how to take these open, frugal, low-cost technologies and translate them and not just do these designs. And that's a real challenge, I think, in the community, that I want to spend my next 5 to 10 years thinking, about how to do this impactfully, not just show these things.
Well, Saad Bamla, that was really fascinating and really interesting. And I salute you for what you're doing and innovating. I'm glad you're doing it. The next section, we're going to go to Sunita Singh. And she is a doctoral candidate in demography with the Institute of Population and Social Research in Mahidol University in Thailand. And she comes from a multidisciplinary background, earning her first master's degree in ancient Indian history. And then the second master's was in training that involves monitoring and evaluation. Doctoral research includes infertility, sun preference, violence and mental health in Northern India. And Sunita was an external review group member of WHO guidelines on health policies and system and support for community health workers. And we're going to hear about health delivery care in India. Thanks for joining us, Sunita.
Thank you very much. And I'm really honored to be here. And I'm really excited, and it was a very nice presentation. And I'm not an innovator. So I'm just talking whatever, it has been done in the past by different, health activists, over the period of time in India. So basically this ASHA program, which was, came out of different health, basically doctors who were working in remote areas, and there was very less infrastructure. And they needed someone to work with, and they trained village women to work with them. So that's how, and different models were used in different parts of India. And like Maharashtra, they use Dr. Bang, they use in Maharashtra to neonatal care. And then there was a Chhattisgarh, there was a Mitanin program was carried out. So that's how they, and then ASHA program emerged from this. So basically, it came into existence with the National Health Rural Health Mission, which is now called National Health Mission, in 2005. And ASHA means in Hindi hope. And these are the local women between age group of 25 to 45 and from the village. And they come there. Initially, it was thought that they should have minimum education of 6 years, but later it was increased to 8 years. And some of these states, they ask for at least high school. And but still, it's very difficult to find in remote areas, especially in villages, to someone to be high school pass. And They are taken as a volunteers, and they are paid in incentive basis. There is no fixed salary. That time when in 2005 they were just introduced, and these women are either married, widows, or deserted, or belong to marginalized community, like Dalits. I don't know if you all know the caste system in India, so they should be coming from lower caste group, lower strata of the community. So they were introduced, they were made ashas. And their selection process was quite rigorous, and also it's a very community participation was ensured in this entire process. Those women, they are very active in the community, or community knows them very well, so that those women were taken on as asha. And local level body like Gram Panchayat or any other bodies were involved in the selection of ashas. Till 2018, there was like 9,339 ashas were there, but it says that it should be more than 100,000 ashas, but still some of the places we don't have enough ashas. So why we thought of ashas, and what was the scenario before 2005 in India? So if you look at the Indian health structure, health system, it was before 2005, it was a very top to bottom approach, where all the policies used to flow from the central level, and they used to go to a village level. Then there was lots of inequalities, equity was there, and social justice was one of the issues when before 2005. So when the rural health mission was introduced, and it was basically to break this entire set notion was there. They wanted to break that, and they wanted to bring it the bottom to top approach, where the policy should be emerged from the village level, and village level people should be empowered in terms of demanding what they want. So that's how, and who will mobilize this? Local level committees, and also who will bring, there was a huge gap in terms of seeking healthcare. There was a huge gap in terms of, people going to the public health services. All the services were very crippled down. Like, we have 4 tiers of health system in India. At the bottom level, sub-center level, then primary healthcare, then community health level, and then the district and tertiary level healthcare system you will find. So most of the, maternal deaths were quite high. Neonatal deaths were quite high. And there are lots of problems, and women they did not want to reach out to the for the delivery, or for any healthcare. They did not want to reach out to the public health facilities, and therefore there are lots of out-of-pocket expenditure was quite high during before 2005. So that's how government thought that we need to come up with a bottom to top approach, because all the needs. India is a very diverse country. Even if you go to the state or village, you will find different people's needs are different. So they said that we need to know what is happening at the ground level, and then who can tell us. They said that there should be a point person, and Asha. That's how Asha emerged, and then Asha who can just link between community and also the health system. So they are the link worker, and they are the educator, they are the promoter, they are the they try to motivate community to come to the health facility, and they are the service providers. I will just talk about it later, how they are service provider, and they are taken as an activist. So activists in which sense? Social justice. They try to bring in social justice in terms of inequalities, reducing inequalities, equities, and then that's how they bring into social justice. So that's what ashas are. I will talk about milestones of Asha program, because this will help you to understand what has happened over the period of time. So in 2005, when the National Rural Health Mission was launched, now it's called National Health Mission. And so it was proposed that ASHA program should be there, and government said that, okay, we approve this ASHA program. And it was in 2006, it was first it was launched at in 18 high focus states, which are, they were not doing very well in all the development indicators. So that it was introduced, and later on it was expanded to other states also. And 2010, the government thought that, okay, there's a training, is a skill development is a very one of the biggest component of ASHA program. So they started a very organized and very structured training program for ASHA workers. And then the first, and there is one mentoring group for ASHA's, ASHA mentoring group, and there is a health system resource center which is housed in Delhi. So they have this ASHA mentoring program. So they started, very periodically they started doing evaluation of the ASHA program. The first evaluation was done in 2011, and then it feeds back to further program development. And in 2013, government launched our urban health mission. They said, okay, there is a rural health mission, but we also think that there are urban poor who are not able to reach out. Out-of-pocket expenditure is quite high. They are not going to the health facility. So they started, urban model of ASHAs. And there was a guideline which they revised the guideline, and whatever the incentives was given to ASHA, that was also revised, because there is a history behind it, because ASHAs were complaining that they do lots of work and not much money has been given. And actually when I did my study in 2 states, in Uttar Pradesh and Rajasthan, I found that they are overworked, and all the programs run through them. So their demands were quite genuine. And then 2014, they started ASHA certification. Why it was needed? Because they wanted that ASHA should be, whatever they are delivering, it should be very up to the mark, and also it should be very standardized. So they started a certification of ASHA program, ASHAs. And then series of training they started, and also mobile academies through mobile, through there was a on-site training. So there are many things, many layers of it. And 2017, through ASHAs, universal screening of NCD was done. And after that, excuse me, yeah. So in 2018, this Ayushman Bharat program was launched in India, which is, which talks about health insurance for the people, especially for the poor and marginalized people. It talks about. So under that, Center for Health and Wellness centers were established to give the quality health services to the poor of the country. So ASHAs were one of the key components under this health Center for Health and Wellness. They were just one of the key components. And then also the government, because there was a parallelly there was a ASHA there was a ASHA movement was going on, where they were demanding that government is taking a lot from us, but they are not ensuring anything, and we are still activists, we are still on incentive basis. So the government revised their packages, and also they said that some of these states introduced, health is a state subject in India. Central can give directives, but states decide what they have to do. Although this ASHA program is the central sponsored program, but some of these states, they said we will give salary to ASHAs, and a central ministry also said that we will give certain amount, like 4,000 is given to ASHAs now. And after that, there is a comprehensive primary healthcare program was launched, and then ASHAs were one of the key pillars of this program. So when we talk about really what ASHA's responsibilities are, when we talk about frugal innovations, this is a really very frugal program. If you look at the amount of money governments gives to these health workers, and then the kind of work they do it, there's no comparison between both of it. So basically their role is to, their responsibility is to, they started with the maternal health services and child health services, because maternal mortality was quite high when before 2000, it was quite high. So they wanted, government wanted that they should motivate, women, and they should, also follow up all the newborn born. So they, if there is any problem, they can just refer these women or children to the upper level. And then they were also, their responsibility was to, to motivate community about the nutritious food, or, government programs. There are several government programs are running, and mostly community doesn't know about it. So they should go and talk about to community about this. And also they have, drug depots. They have drugs. So, just for like malaria, tuberculosis, diarrhea. So they have the, it's called, kit, and they carry that. So government made them depots as well. And mobilization, for planning, as I mentioned that, bottom to top approach. So how it will be done? So they have to talk to community. They have to mobilize community for this, that community should come in. And then also, they should talk about their needs. They are one of the empowering process. One of the biggest empowerment is coming from through this ASHAs. They are motivating women. They are asking them to come out. So that's how they are working in the community. And also they do surveys for health and related events. So if you look at that, most of the programs are running through ASHAs. And if any new programs comes in, ASHAs are the first point person who are contacted by the government authorities. And they have all information because they are from the village, they are the local women, so they know each household. And every 1,000 population, one ASHA will be there. Suppose if there are 5,000 people living in a village, so there will be 5 ASHAs, and they are, all the areas are divided, and then they know very well their community. And national health programs are, like malaria, pregnancy related, they just do it. And family planning is one of the biggest program in India. And ANC checkups, because earlier, women used to not go for ANC checkups. So like, immunization, ANC checkups, and, family planning programs. So ASHAs, carry forward this program for government. And because of this, if you look at the, we recently have got the national health NFHS data, and you find that, our TFR has come very sharply, has come down. Now we are at nearly replacement level fertility. We have got like 2.15 now we have. So it's because of the rigorous program of government of India. So this, I have colored out some of the pictures during my field visit. I just collected these photos. I clicked these photos. You can see that, they are doing the local level, this, they are making a village map. And then that's how they do the planning. And, this is the CSC, local CSC, community health centers, where they meet and they talk to ANMs, they all the ASHAs, they get together and they talk. And, this is one of the household where one of the ASHA went, and then she was like 10 household they have to visit every day to find out, child health, elderly health, or, if a pregnant woman is there, or if somebody is visiting from outside, they just take record of everything. So that she's collecting information about the household. So now I will talk about, like, what they are paid and how they are paid. And so this is a theme-wise payment of ASHAs. So you can see that maternal health is there, child health, immunization, family planning, adolescent health, and Nirmal Gram Panchayat program. This is Nirmal means, clean. So clean village program, which which is introduced very recently because of Ayushman Bharat program. So there, they talk about Ashas motivate, community to build toilets, because, basically, if you look at in India, not every household has toilet facilities. So government wants that people should build up toilets. So this is also one of the biggest exercise for ASHA workers to go and check every household and just try to motivate them to, okay, build this household, government get toilet, government is giving money. So for them it's basically talking, communication, and also motivating is a big challenge, and also one of the activities, you can say. Adolescent health is also like, sanitation is big issue, sanitary napkins, distribution of sanitary napkins. And they also talk to adolescent about their reproductive health, and also, menstrual hygiene. So every month they meet with adolescent health and talk, and they are paid for this. These are the activities they conduct, and they are paid. Not a lot of money, like 50 rupees will be like even less than $1, I will say. Like $1 is 77. If we exchange $1, it will be 77 rupees we get. So it's less than less than $1 they are paid. Some of the activities they are paid, and some of the activities they are paid $1 per activities. And family planning, like family planning is still, government is putting lots of stress on this. And then I have worked with them, and I've seen that how difficult it is for them to just, motivate community and to get, and also, like, in terms of if male sterilization is there, so they will be paid more. And female sterilization, immediately after, delivery, if a woman is getting sterilized, she will get more money for that. So government is trying to give them, tell them that, okay, you work hard and then you'll get more money for this. And then there is at the village level, there is a village health and nutrition committee set up with, again, it come into existence with National Rural Health Mission. And the main objective of this committee is to develop plans and look at take care of the health of the village. So ashas are member of this committee, so they have to organize the meeting. And in this meeting women and adolescent girls are called, and also other people also come in. So there are national health programs, which is government again straight central ministry look after this program, and the funding comes from the central ministry. So ashas have to deliver these national health programs. So like leprosy is there, tuberculosis is there, vector-borne disease is there, and blindness program is there. So there are different activities under that, and they are paid for this, and then they have to. But again, I will tell you, these activities are like not one-time activities. They have to visit 6 months, and then maybe they will get paid like $3 or $4. So this is, they work really hard on this. And now, when you talk about, I will talk about this record keeping and what they do it, in terms of maintaining records. So every 6 months, like every calendar year, they will just make the list of each household in their area, and this list will be updated every 6 months. And village health register will be maintained by them, and every month they have to develop a to-do list, and where number of children will be there, and they have to immunize, and pregnant women, they have to go for ANC checkups, or they have to follow up. And also preparation of list of eligible couple will be for family planning programs, they will prepare. And monthly meetings have to be, or sector meetings have to be attended. And village health and sanitation community, which I have already talked about. So still empowering these women who are coming from a very rural background, and also they are the lay women, never been exposed, they live in Parda. They were not allowed to go out of their houses, and all of a sudden they have become ASHA. So how the government also thought about it, like how to empower, how to train them. So they develop a very strong training program for them. There are 7 modules in their training, and it all the states rolled out, in different phases, and there is a very trained trainers, they come and train them. And so there are, these models on different topics, which I'm not going to talk in detail, but these are the introduction of ASHA program, what ASHAs are, what their values are, and how to work as an ASHA, maternal and child health, family planning, and RTI, STI, and HIV. It's how to diagnose, how to see, how to talk to people, and national health programs, different national health programs, and self-development, like how they should develop themselves as an ASHA. And if you are an activist, how you should work an activist, and a skill that saves lives. It's basically, it covers all the maternal and child health programs. And there is, special modules are there, which emerge while, different monitoring and evaluation program, like, violence against women and reaching the unreached. Like, how would you reach very remote and very marginalized community? Like, if you talk about marginalized, they are very poor, nomadic communities are there, Dalits are there, and some of the, those people who have very chronic have illnesses. So usually they're outcast in the community. So, ASHAs are trained to reach out these community and talk these people, and then try to bring them into the mainstream.
Sunita, we're kind of running out of time here. Got a lot of questions.
5 minutes, or how much time I have?
Maybe a little less than 5. Couple.
Okay. So I will finish. I will wrap up. So in terms of talking about technology and empowering them, so government has come up with a different mobile apps for them, like Kilkari Mobile Academy. Mobile Academy is for ASHA training program and to develop their skills. And this is one of the ASHAs, and then she's using one of the mobile device for the message, and she's trying to tell women, like, what are the messages are. And this is the mobile kunji means key, so different issues are there. And this whole ASHA program is a very empowering process for women, and they share a very great sense of sisterhood within the community and also with ASHAs. And also they work as a mentor for the newly appointed ASHAs, and they help each other, on different, like, violence against women came up one of the biggest issue in the community when I was working in ASHA's family, and also the women from the community. So they really helped and reached out this community, and they have become very vocal. So Seva means, selfless services. So they really enjoyed this, and they said, we are not working for money, we are working to serve community. And they are very strongly associated with private hospitals also. It's also empowering for the community, because they are a big negotiator with the private hospitals. So private hospitals cannot cheat people on certain issues, because they know the prices. So they negotiate for the community, and they get some commissions, on certain issues from the private hospitals. So yeah, and this is, that's how, government has acknowledged and honored, ASHAs. We had this 26th January was a Republic Day, and they were just, ASHAs were, shown in this Republic Day. And that's what today is the Holi, our color festival. So I wish everyone happy Holi. And these are my community health workers with whom I worked for 1.5 years. Thank you very much.
That was really fascinating, Sunita. And I think about we're wondering, how big of an impact did it make on community healthcare? Were there results that were tangible? If going into this, everybody wanted to stop infant mortality from being so bad, were there results?
Yes, there are lots of studies. It's not, I'm not talking about something, because this program has been like past 15 years now in existence, and they have really done a lot of, qualitative and quantitative changes in the community in terms of maternal mortality, neonatal mortality, sanitation. And if you look at the data management has been improved. So there is a huge change in a community level, and specifically if you look at the village level, because Indian health system is a very complex system, and accessibility had been a big issue, And so, because of the community health workers, these ASHAs, there are a lot many problems have been solved. They are the backbone of the, now, even government says that, you all are the backbone of health system. Government can't, move any step without them.
There was a question about trainings for the village women and how they were delivered to them and how you get participation. It seems to be that participation can be a problem in some of these instances. How do they do it?
Okay, so training is very well organized. So as I mentioned that there is a ASHA mentoring group, which is, housed in, which is organized by National Health Resource Center, which is in Delhi, and they are very technical organization. And mentoring group had designed all these modules, which I mentioned, about 7 modules. And these are all people who have been working in the health area from so many years. And they're and then what happened, there will be a resource pool has been, developed at the national level. And this resource group goes to every state. And then there is a state resource group has been developed with the help of them. And there will be ASHA mentoring group at the state level. And that's how, percolate, from the national level to state level, then district level, then it goes to the village level. And then at the CSC level, the training, so ASHAs don't need to travel very far because most of them are married, have children, so they can't, just come and have a residential training. So it should be reachable, accessible for them. So it has been organized at the level of where they live, or very close to them, like 5 kilometers away from where they live. So the government makes sure that it should be culturally appropriate, and also it should be good for them, so they can just leave their houses and go and attend training.
All right, another quick question. How could we create ASHA programs elsewhere in the world? I mean, would you recommend this? Is it a good idea? Would it work in a developed country like the United States with an extremely capitalist healthcare system? We could all use reminders about our healthcare and some kind of engagement with, maybe the Walgreens Quick Care person is becoming our ASHA program or something.
Yeah, what I understand about, I don't know much about American health system, to be very honest about it, but whatever I have seen and I have understood, it's a very tertiary level and very private health care you all have. That's what I've understood. I think you all have also this community outreach program is there. Some of health workers are there. But I think you have to do in a very cascade manner. It can be done, and it will be like those community which is like homeless, or those who are not able to have healthcare facility. Out-of-pocket expenditure is very high, so you can train, and it can be done. But I can't see right now like how it could be done. It's possible. Nothing is impossible. Like when we were thinking about ASHA program, we're thinking how it will be done in such a huge country, diverse country, where health is a state subject, but it is doing wonders. So I think mostly, in developing countries, I've seen, in African, and if you look at Bangladesh, these programs are running they are doing very fascinating work.
Well, that was a very fascinating presentation, and they're very thought-provoking. And thanks very much, Sunita Singh, for the presentation.
Thank you very much. It's an honor. Thank you very much.
You're welcome. And now we'll go to our final presentation of the morning, and I'm excited for that as well. And it's coming from Rebecca Richards-Cordum, and she is the Rice University professor, Rice University Malcolm Gillis University Professor of Bioengineering, and is the director of Rice 360 Institute for Global Health. She's the author of the textbook Biomedical Engineering for Global Health, and her research has led to the development of 40 patents. And as a member of both the National Academy of Sciences and the National Academy of Engineering, she has the rare distinction of dual membership in the National Academies. She is currently working with colleagues and undergraduate students to develop a nursery of the future to provide technologies necessary to reduce neonatal death in sub-Saharan Africa to rates that are equivalent to the United States. This effort, Nest 360, will bundle effective and affordable devices and train clinicians and develop locally owned data to drive quality of care. And I am excited for the presentation, Rebecca Richards-Corda.
Thank you so much. Can you hear me okay?
Yes.
Perfect. So it's really a pleasure to be able to join all of you today and share a little bit about the work that our team is doing to build a global network of frugal innovators that have the tools that are needed to end preventable newborn death in Africa. And I want to just start by noting that there's been a shift in the place of birth in Africa. Now most babies are born in hospitals, but still every year more than 1 million babies die. And 3/4 of these deaths are preventable with technologies that both exist today and are affordable in these settings. And I think this is just a tragedy that we cannot let continue. These deaths could be prevented. And when I think about the role that frugal innovation can play, I hold two pictures in my mind. The first is a picture like this, which if you go to a district hospital in rural Africa is very, very common in the newborn ward, where you see many small and sick babies who are sharing cots. They're being cared for by well-trained, dedicated clinicians, but who have a very high caseload. And if you think about what you would see if you went to a neonatal unit in a hospital in a high-income country, that unit would be full of a lot of life-saving technologies. Instead, in many hospitals in low-resource settings, you find places like this. We like to call the equipment graveyard. And this is where technologies that have been designed to work in high-income settings are taken when they fail because they weren't designed to withstand the heat, the humidity, the dust, the difficult conditions that exist in a low-resource setting. And I often think that medical devices should come with a warning label. And the warning label should say, this medical device can only save lives if it is used. And as technology developers, I think we really have to pay more attention to what are the barriers to use of technologies. How can we design technologies that are more fit for purpose? So I want to start with one of the very first technologies that our team developed to address this need. And it was motivated by a pediatrician that introduced us to the challenge of neonatal respiratory distress. And more than half of preterm babies suffer from respiratory distress syndrome because their lungs lack surfactant and they really struggle with the work of breathing. In a high income setting, respiratory distress syndrome would be easily treated with a technology called CPAP, continuous positive airway pressure, where a mix of air and oxygen is blown into the baby's lungs through soft prongs in their nose and just provides extra support while their lungs mature. But CPAP machines cost between $6,000 to $10,000, and they're really not designed to work in low resource settings. Back in 2010, a pediatrician colleague in Malawi showed our team this setup, which was a bedside CPAP machine that they had created using frugal innovation. They took a vacuum pump and reverse engineered it so that it was a flow driver. That caused it to overheat. So they used this kitchen fan to blow on the vacuum pump so it wouldn't overheat. And you can see here is the pressure regulator in their homemade CPAP system. It was affordable, it was rugged, it was not simple to operate, and it didn't meet international regulatory standards. And so they asked our team to develop a low-cost CPAP system. And here you see a team of students. They graduated in 2012. And they built an affordable CPAP machine, this prototype that they're holding, they were able to build for about $150. It used 2 aquarium pumps as flow drivers. And they were able to work with our pediatrician colleagues at Texas Children's Hospital in Houston to show that it did the same flow and pressure as the CPAPs used at Texas Children's. And so one of the women that you see in this photo, Jocelyn Brown, worked after she graduated as a global health fellow. And she took that prototype and she made it more rugged and used it to carry out a clinical trial. And then she worked with a company in the Bay Area called Third Stone Design to commercialize that CPAP device. And here you see the commercially available product. It's gone through international regulatory approval. It is 1/10 the cost of devices that are used in high income settings. And it has now been sold in over 36 countries and just received an award for helping over 1 million patients. What Jocelyn was able to show was that CPAP device raised rates of survival for preterm babies who had respiratory distress from 25% to 65%. And that's very similar to what happened when CPAP was introduced in the United States in 1971. But for her, I think what was especially meaningful and really for our whole team was to see what happened to Chikunbetso, the little baby who was suffering from respiratory distress that I showed you earlier. He was born when that trial of CPAP was happening in Malawi. He was treated with CPAP, and here you see him just after his 2nd birthday, and he's doing very, very well. We've had a whole team of global health fellows that have worked in Malawi to carry out a whole series of research studies to look at the impact of CPAP and how you introduce it at national scale. And it's now available at every district hospital in the entire country. What we showed at the teaching hospital first was this improvement in survival from 25% with oxygen to 65% with CPAP. But as we began rolling it out across Malawi, what we found is that we were delivering CPAP into district hospitals that were very poorly equipped. And you can see really, here's one example of a district hospital that had only cots and the CPAP devices that were delivered. And what happened is that the outcomes with CPAP were not as good in that setting. We saw survival rates only at about 40%. It's better than the 25% we saw with oxygen, but it's not at that 65% level. And of course, we realize that babies need many technologies to do well. They need to be kept warm. They need diagnostic devices. They need to have jaundice treated if they suffer from it. And so we carried out with the Ministry of Health a ward strengthening program where we delivered a bundle of technologies. And we looked at what happened to the outcomes for babies who were treated with CPAP. And what we found was that when we delivered this bundle of technologies, then the outcomes with CPAP improved up to that same 65% level that we saw in the initial clinical evaluation. And this happened at about the time the MacArthur Foundation was running the first version of a competition they called 100 and Change, where they were going to give one team a grant of $100 million to solve a big problem in a sustainable way. And so our team, along with 2,000 other teams, submitted a pre-proposal to the 100 and Change competition. We made it to the final round, but unfortunately, we did not win the competition. Our team decided to persist together, and we were able to raise from a consortium of donors $68 million to put our plan in place in 4 African countries. And so now our team, which is an alliance of 16 different organizations in the US, the UK, and Africa, is working to deliver a package of technologies, but to do that as part of a health systems approach where we're strengthening education for clinicians who are caring for babies. We're strengthening education for biomedical technicians who are caring for the equipment. And we are working with the Ministry of Health to strengthen policies for newborn care and policies for health technology management. And so we have also worked to develop additional technologies that can be part of that bundle. And like the CPAP device that I showed you earlier, many of these got their start as undergraduate design projects. Billy DX that you see here was just released commercially, and as part of the NEST bundle, it's a point of care bilirubinometer to determine whether or not babies suffer from jaundice. CELSI Monitor, we're expected to have available the international regulatory approval early this year. Again, it began as a design project and now is able to provide continuous temperature monitoring. And Neopanda, the device that Sylvia showed you earlier in her talk, is another device that we're evaluating for inclusion in NEST, and it also just received international regulatory approval. So it's really amazing to see the work of so many undergraduate level frugal innovators coming together to have this kind of impact. I want to close by sharing what we're doing at Rice to try and build a network of frugal innovators. So first, what are we doing at Rice? In our Institute for Global Health Technologies, we tried to bring together problem owners, people who have needs for technologies to improve the delivery of healthcare in their setting, and problem solvers, people who have ideas about how to design and deliver technologies to meet those needs. We have a minor in global health technologies at Rice, and this is a project-based program. It's open to students in every major. It has 5 core design courses where students work to solve real problems that come from typically healthcare providers in low resource settings. And they're mentored through that design process by faculty, graduate students, and clinicians in Houston and in partner low and middle income countries. There's also an internship. It takes place during our summer, and it is a bi-directional internship. So we send Rice students to 4 countries in Africa. Students from those countries come to Rice, and then there's exchange between universities in Africa. And they all work together for 6 to 8 weeks to carry out design projects that can make a difference. And many of these projects turn into their capstone design projects. We have a 2-year-long post-baccalaureate global health fellowship. Jocelyn Brown, who I told you about, was one of our first fellows, and she really pushed the CPAP device forward. Christina Samuel here, who you see on the right, came from Malawi to Rice and pushed forward a device to monitor preeclampsia in pregnant women. And we sponsor an international design competition. The finals of that will be held next Friday, and welcome you all to tune in and see some really exciting developments by students from all around the world. But I think most importantly, we've tried to bring together an African-led network of universities that are incorporating invention education for not just biomedical engineers, but for all engineers as part of their curricula. We have worked with engineering schools in Tanzania, in Kenya, in Malawi, and in Nigeria to carry out curriculum review to look at places where they could incorporate project-based and problem-based learning that is focused on solving health challenges using frugal engineering, to build engineering design studios that provide rapid prototyping spaces for students, and to connect engineering faculty with clinical faculty at medical schools in their own communities. Together, a network of 16 different institutions in Africa, Europe, and North America came together to launch an online invention education toolkit that has just a wealth of resources to help universities work to implement and strengthen invention education programs in their own settings. And we really saw during the pandemic the impact that these engineering design studios and invention education programs could have. All across Africa, students and faculty in the design studios worked to develop and roll out innovations to help keep healthcare providers and patients safe during the pandemic. In Malawi, the design studio produced over 80,000 face shields. Those were purchased by UNDP, and this provided a really important and now continuing revenue stream for the engineering school to help them purchase supplies to be able to expand design education in their setting. And I want to close with just one example that I think shows the power that this approach can have through cross-university collaboration. And this is a program that's focused on the prevention of cervical cancer. And so I'm going to start over here on the left. You see these three students, Mary and Wahid from Malawi and Karen from Rice University. So all three of them worked together during a summer internship. The problem that they were given came from the Cancer Center in Houston, where the gynecologic oncologist that we were working with said, I'm trying to train nurses to do cervical cancer screening and diagnosis. And I need a model system that will show them the changes that take place in the cervix when you put this contrast agent called acetic acid on it. And so the students had the really great idea to paint these models of the cervix with thermochromic paint. And if you applied hot water, they would have the same acetyl whitening change and it would fade in the same way that it actually does in the cervix when you are screening for cervical cancer. They were supervised by an MD PhD student named Sonia Para. And Sonia traveled with our colleagues from the MD Anderson Cancer Center to Mozambique. Mary and Wahid came from Malawi to Mozambique to demonstrate these cervical cancer training materials in a course that was being used to teach healthcare providers there. They worked with some more students at Rice, including Karen and Sonia, to develop an entire pelvic model that could train healthcare providers to do a pelvic exam, to take an HPV DNA test, to do all of the tests that are needed for cervical cancer detection, diagnosis, and treatment. And then Wahid worked. He employed a whole army of engineers and artists in Malawi to make 50 different sets of these models that were then disseminated to cervical cancer training courses and used in Texas and other places in the US and in Latin America and in Africa. And I think it's a great example of both the local and the global impact that this approach can have. Wahid is now on the faculty at the university there and continuing this type of work with students at his own university. So let me stop there and I'm happy to take any questions. Thank you.
Yeah, that was really terrific and congratulations on everything you've accomplished. I imagine this was almost more than you expected when you got into this. You wanted just infant mortality to stop, but you have a grander application here. You've broadened the whole deal. When did you know that was happening?
Yeah, it was such an interesting journey to sort of see how we started with this one small goal, meeting the needs of helping tiny babies breathe, and then seeing how many other problems existed in that same setting, but also seeing the power of engineers in that community. So it really happened organically over time to just build these coalitions and continue working together to try and take on all of the healthcare challenges that exist in that setting.
A question came in about how many CPAP machines you are able to deliver now, if you're able to do this on a large scale. Are there strategies for mass production, marketing, distribution? You're working with governments, ministries of health. Do they do it for you? How does that work?
There have been tens of thousands of CPAP machines that have been delivered commercially. And so what Rice did was we licensed the technology with zero royalty because we wanted to keep the price as low as it could be kept. And we licensed it to an organization that had a commitment to fulfilling needs in low income settings with pricing guarantees in those settings. We found actually that the challenge was bigger just than commercial manufacturing, though. There was also a really significant challenge with commercial distribution. And so we've worked to create a nonprofit global distributor that's called Hatch Technologies. And Hatch is working to connect manufacturers to local distributors in Kenya, Malawi, Nigeria, and Tanzania to help be sure that there's a source of quality technology and also the follow-up in terms of preventive maintenance and warranty service.
All right, that's a little complicated. That's entrepreneurial. It's entrepreneurial. So is that organization a nonprofit? One of the questions is about do you work with smaller nonprofits? Do you work with mostly just universities? You seem to be working with.
We have worked both with for-profit. Yeah, we worked with both for-profit companies as well as nonprofits and universities. And originally when we started this work, we thought we would go faster if we could connect to large medical device manufacturers. And we found actually that wasn't the case, that we were able to go faster by working with small and medium-sized organizations that had the same commitment to global health equity that our team did. They were able to just act more nimbly and really get through the regulatory approval, the commercial manufacturing with appropriate quality standards, and to help think about how to solve the distribution challenges.
Did you describe everything that's in the bundle that a nursery gets? Because it seems like you described a few things, but it might be more. And also how much training is involved if you're, do you walk in there for 2 weeks or do you have to walk in there for 2 weeks a year for all year long, for a month or something? How does it work?
Yeah. So the bundle includes the technologies that are recommended for WHO level 2 newborn care. It's a set of 16 different devices that help keep babies warm, help them breathe, help provide basic diagnostics and treatment of neonatal jaundice as well. We went through a commercial sourcing exercise. So we started with UNICEF and worked with UNICEF to develop target product profiles for each of these product categories. And then we just looked at what was on the market. We bought them, we evaluated them, we subjected them to really harsh environmental testing, and then qualified the ones that were the best value for money. And so the bundle includes really only one technology that was developed by our group, the CPAP, and then others are commercially available from other sources. And the training includes 2 parts. There's an installation training where you bring together the nurses and doctors on the ward and the biomed techs that are providing support and do a 1-day training. That's basically, how do you turn this on? How do you turn it off? How do you set it up? And how do you maintain it? And then in each country, there is a national curriculum for newborn care that is the standard for providing small and sick newborn care. And in each country, we worked with the ministry to strengthen that nationally approved curriculum to include more instruction on hands-on use of devices. And those courses are typically 3 to 5 days long.
All right, great. And is there, it's interesting, you work, it sounds like exclusively with undergraduates practically. until they move on to their fellowship? Is there an advantage to this? Do you like it? Is there would you take a graduate student if you could get them? How do you, or do you like engaging with undergraduates in Africa? Why do you do that?
So it's actually been a really close collaboration between undergraduates, the fellows, and graduate students. And I think the thing I love about working with undergraduates is they're so fearless, and they're not constrained by their fear of something maybe not working. And so they come up with these really amazing out of the box ideas. And sometimes you hear it for the first time and you just think that will never work. And then they prove you wrong. But I think they also have a limited time in their program to think about carrying an innovation from a promising idea all the way through to the end. And that's where I think having this combination of undergraduate students and graduate students working together and fellows is so critically important. And so on all of these projects, there's either been a big contribution from a fellow or from a PhD student or an MD PhD student in some cases that was needed to get it all the way across the finish line in terms of looking at clinical evaluation and getting it ready to the point that it can be commercialized.
Who've been your biggest backers? It sounds like you were really counting on the MacArthur Fellowship there for a minute there, but then found big backers of your own. Who are they? Why do they want to do this?
So one of our earliest supporters is a foundation called the Lemelson Foundation that has invested in invention education, both at the K through 12 and at the tertiary level. And they gave early support that made the Pumani CPAP possible. When we went through the adventure of the 100 and change competition, we came out the other side with a consolation prize from the MacArthur Foundation. And it was, as consolation prizes go, a very nice consolation prize of $15 million. And we were able to use that to approach 3 other foundations to co-invest. And they include the Bill and Melinda Gates Foundation, the Children's Investment Fund Foundation, and Elma Philanthropies.
Well, that's terrific. Do you have a ballpark idea how many children, how many babies you might have saved in the course of this? It seems like if you were to add it up, it would be a lot.
So every year now, when we look at the hospitals that are served by the NEST program, it's over 500,000 babies who are born in those hospitals every year. And I think, as a mom, every time you're pregnant, it's such a scary experience, and you worry so much about your baby's health and are you and is your baby going to be safe during labor and delivery? Nobody knows when they're going to have a baby too soon. And so I think it's important for every single one of those babies and families to know that they can have a hospital that is prepared to be able to provide quality care for small and sick babies. We all need it everywhere.
Well, it's an awesome thing you've done, and congratulations on your work. We're going to bring everybody in now, all the speakers who've been involved, and we'll have a kind of a group chat. And there's certainly some cross-pollination in some of the things that you do. Here we go. I'm going to see them, I assume, as they pop up. Hey, there's Saad. Are there things that you've heard yourselves that are resonating when you hear the other people talk here? I imagine, Saad, you've developed a couple of things, but would like to see greater applications. And You know, it sounds like Rebecca's got a pretty good, has applied things. Although, how do you see, how do you hear each other?
You know, it's very inspirational. I've been following your work, Rebecca, even when I was a graduate student and early postdoc, and I am appreciating now that I think the engineering part is one, but I think what Rebecca's team is doing just spectacularly well is essentially the whole pipeline, right? From the education, from the regulatory part, and the manufacturing, and the training, and then the follow-up. I wish there was a course I could take. I wish there's a book on this that helps understand how to do this. And I almost like for startups, there's this valley of death, and we can make these things, but to train the next generation of scientists, including myself, to actually do that last leg, it's just so, it takes more than a team, right? Does that make sense? So I struggle with this, and that's essentially what I'm realizing, and that's going to be the focus. I can make widgets. What next is the question, and I find that that seemed the difficult part, but that's actually the easier part. The next stage is actually the crazy hard part.
I
don't know if that made sense. But, yeah.
that made sense to me. Sylvia, do you have experiences like that?
Well, it was amazing to watch all of you and how you all, using your very specific areas. I'm not in the medical area, as I said before, and it was really amazing to see, Rebecca, what you're doing in your side also, and Sunita, we're all doing very interesting work. And Rebecca, you have built a huge portfolio of solutions that are really amazing. And I actually, I'm just looking you up, and it's really cool what you're doing at Rice, and I'm really impressed by that. So yeah, we are different in the sense that we are broader, and we have like mechanical engineers, bioengineers, civil engineers doing things in the water. So we are a little not as focused as you guys are, so a little different here, but I'm really amazed by everything you guys are doing.
Do you work with any engineers, Rebecca?
I think, one of the things that that is such an opportunity in this area is, I think, of course, we have many projects that don't get to scale, and that we think are promising, but somehow they just never get to scale. But I never look at them as failures, because the students always learn. And I think that's sort of the thing that can keep you sane in this field, is that the valley of death is vast, and it's hard even in a high resource setting to get through the valley of death with a new innovation. It's even harder in a low resource setting. And so, if all you're doing is trying to get through that, you're just like always failing. But the wonderful thing about the undergraduate design projects is you're not always failing, because students are always learning. And I think they're learning in a way that helps them see another approach to technology, an approach to technology that can reduce inequity rather than perpetuate inequity. And so I think, that's one of the common themes across all of the work that was presented here. And I think there's inspiration in that every day. And I think probably for all of us, it's that keeps us going and draws us to this work.
Yeah, I'd like to add to that. One thing that really motivates me is actually seeing how the students understand the power of their degree, how engineering can change the world. And I think we need to get the students to understand that, so that when they go out, they actually have that in them, that, I know enough that I can make an impact. And I really value that. I'm not an engineer, I'm a computer scientist, but I live in a school of engineering, and I think that is a really a powerful actually feeling that you have enough skills to make an impact. And I agree with you, Rebecca. There's no failures here. There's lots of projects that didn't go anywhere, but the students learned a lot, and that's really rewarding.
Well, there's a question here, and people can lob things in the question and answer and participate too. Could each of you list the biggest challenge you faced as scholars working in frugal innovation? Do you have a biggest challenge?
Well, I can start. Mine is deploying. Sometimes people ask for something and you do it, and we go through several interactions until you finally, have it. But getting it to the field, it's a challenge. Sometimes people are not ready for that, even though we built exactly what they thought they needed. But this last mile deployment of solutions sometimes is where we fail.
Saad, my conclusion from your presentation was it's capitalism. Capitalism is irreversible.
Maybe that's not the conclusion I wanted you to take, but perhaps that's the assistant professor in me who was trying to figure things out. Maybe a comment. Lately, I've been thinking about the idea of some of these closed technologies as we think about them, and the idea of open technologies. We appreciate them in open software, for example. Quite all of us may use Chromes and Androids, and thinking about open hardware, not just in the sense of using 3D printers, but as you get to biomedical hardware, whether it's vaccine delivery or CPAPs or respirators. I think there is an opportunity here specifically for global health, because whether we want to build PPE, we can, there's a democratization of the open hardware, but what I sense sometimes is missing is you have to work very tightly, because in biomedical fields, these are linked with tight regulatory and, frameworks. And if you kind of ignore that, it's to your peril, because during the COVID pandemic, a lot of maker spaces want to do something, but if you don't do it up to a thing, it's not accepted. And the frameworks and the policies for each country, whether we think about hearing aids or whether we think about vaccine delivery, can differ and maybe non-existent. But I think there's a huge opportunity as we think going forward, not just for the problem of today, but as I'm thinking about the power of, say, mRNA vaccines for not just COVID, but for, cancer and HIV. But again, we might run into the bottleneck of regulatory pathways and open biomedical things. So I think that's something I may not be making sense, but I'm thinking that there might be efforts needed to help bring some of these and create frameworks. So there is the engineering problem, but I think there is a more framework and legal problem that I wish I had the vocabulary and the bandwidth to think about and expertise, but something I just wish I could think more deeply about, because I think that
You're kind of talking about a regulatory standardization that allowed for more open technology.
Perhaps, yeah, that gives more options than kind of closed box solutions, but because biomedical life-saving things, there's a huge amount of trust, right? You need to know you can rely on it. And one approach we do is the company's approach, but if we had alternatives, I think it may open up more local grassroots innovation. And that's something I think about, especially even biomedical hardware. It's more than just buying a pair of glasses. So just a thought.
Rebecca, do you have some reaction to that? I mean, is regulatory issues, how often is that a factor for you?
I think regulatory issues are a big challenge in a lot of ways. I think, especially for devices, there is not a consistent regulatory framework that's used across Africa. So, the approach that we took in our team was to say, we're only going to look at things if they've gone through one of the big 5 regulatory approvals. So, FDA, CE, South Africa. That's where for the NEST program, if it hadn't gone through one of those regulatory frameworks, we just said we're not going to consider it. And that was really at the direction of our clinical colleagues who are working in these hospitals. So I think that's one challenge is Malawi, for example, has no laws regarding medical device regulation. Tanzania has a very complex framework. It's different than Kenya. And so just because your device is approved in Kenya doesn't mean it's approved in Tanzania. And what does approval mean in Malawi? So you have to approach it on a country by country basis. And that is time consuming and expensive. And it's very different for drugs. It's very simple for drugs. But for some reason, for devices, it's different. So I think that's one issue. The open hardware issue is even more complex. But I think the potential of it is enormous, because think about the challenge of just sourcing spare parts. If I had a way of open sourcing spare parts that could be locally produced, it gets a lot of stuff out of the equipment graveyard. I haven't seen a practical framework for that I really think is workable. There are some efforts trying to think about it. There's one underway for respiratory technologies that was in many ways spurred by the pandemic. But I think it's a really important gap right now, and I think it's important need for attention.
I see Sunita is with us. I thought you had slipped away there for a minute. How are you? I think you're moved off.
You're muted, Sunita. We can't hear you.
Yeah.
Sorry, I'm not an engineer and I've not, innovated anything. I'm thinking as a program manager and also as a researcher when I work with, state level or government and as well as the central level. The biggest challenge which I found that if there is anything new you have developed, is scalability and sustainability of that. Because, in order to convince people sitting at the top level, at policy level, had been a marathon task. And I work with certain organizations who develop very low cost and, very, very useful, and that innovation died. I was talking about there are 4 mobile apps which has been developed for ASHA workers. And it was specifically, they just did it in one of the states where I come from. And I talked to ASHAs and they said, really these apps are very good. And they were asking me that why they are not getting any more information on this. And I knew that they have killed that program because they were not convinced and they wanted something else. And then every day there is somebody was giving me a statistic that in India, every day 30 mobile apps are developed, and they go to the policymakers and they try to sell it. So also the competition is very high. This is so when you look at how long you can sustain it and how will you sustain it, and how that who are involved, how much power you have. So this is also one of the issues when you deal with policymakers. And then alone we cannot do it. Suppose if I have developed something and I want that it should be sustained, so it cannot be. I have my own resources and it will get, so this is one of the challenges which I found when I was working on, I reviewed one of the mobile health programs for one of the organizations, and then this is one of the biggest challenge which I found during my research.
Have you had experiences like that, Rebecca, where there's so much competition at the top for, I don't know, attention and just sorting it out that they can't handle it?
Yeah, I think it's so important to think about scale and sustainability from the beginning. And my experience is that partnership with the Ministry of Health from the very beginning is critical if you are going to successfully get to scale and be able to sustain it. There's really no other way to do it. I think I've certainly had experiences where it's so important that the local partners with whom you're working understand the hierarchy within the ministry and who to approach and when, and to think about how your priorities map on to the priorities of the ministry. And, I think for a long time, we experienced that babies weren't very high on the priority list, that there's a lot more concern about maternal deaths than there was about neonatal deaths. In the face of that, it's hard to overcome. There's been a lot of global advocacy to elevate the importance of newborn death, and now you're seeing it change. So I think it's a confluence of a lot of things.
Mm-hmm.
We're going to have to wrap up, but I wanted to ask if there's anything on the horizon for any of you that you're really looking forward to, that is kind of sparking your curiosity, and any kind of new application or new idea that's kind of got you jazzed. Saad, you have a million ideas. I've seen your website.
Yeah, that's going to take more than a few minutes to get through. But, I think I'm also learning. I think what I love, at least doing this frugal stuff, is it's very empowering. And this is stuff I don't need necessarily be at Georgia Tech to do. I could do it if I had a small lab and even the rainforest. And I think that's what I'm looking forward to in the next 10 years or so, because I engage with now students from across the world, high schoolers, undergrads. They can do it. And I think I want to solve some of the problems of today, right? The hearing aid. But I also look at powers of synthetic biology and mRNA vaccination. As we leapfrog technologies, I think the next generation is also seeing that. And I think sometimes they will get to the 5G or whatever it is. And some of these low-cost ways allow them to solve their own problems. I don't need to. And I just, that's what keeps me going, if that helps.
Sylvia, do you have some things on the horizon you're thinking about?
Well, there are some applications we've been working with, particularly for tuberculosis, to diagnose tuberculosis using machine learning. This is one that is a big one for us. And also, apparently, well, not apparently, we're trying to work with the UN on some technology to help refugee camps, which is a big problem right now, particularly with what's happening. So this is another one that it does not relate to health that much, but anyways, again, I do other things, not just health, but that's the big one that we are starting.
Sounds great. Keep up the good work. Sunita, anything on the horizon that you're excited about?
In terms of my work, I just I would like to continue working with my community health workers, because I think they are one of the backbones of the health system. And also, these are the women like me, coming from a very small place, and they are making a huge difference in people's life. So this is what I'm very much excited about. And I would want that there are 3 engineers over here, so they should think more about how to develop something which can be reached to those who are at the very marginalized level of community. Those things are not able to reach, they don't know anything. So that's what my goal, and I'm excited about. And then and that's what I'm working on for next 2-3 years. I will be working on this.
Excellent. And Rebecca, anything on the horizon that's that you haven't already bit off?
Yeah, no, I am really excited about the integration between consumer electronics and imaging technologies and AI. I think it's really going to transform diagnostics everywhere. And I think it has the potential to do it in a way that's affordable and that can be in the hands of community health workers reaching patients at the last mile.
And so you're talking about what kind of technology possibly? It's like,
yeah, really low cost imaging devices that are smaller than cell phones, that have AI powered based algorithms that can be used for cancer screening, for example, to guide surgeries. I think there's just a huge array of medical challenges that can benefit from these kinds of advances.
So you take the picture, you never get a diagnosis from a doctor, and it just, your Google just tells you you've got X. I'm looking forward to that. Well, thanks very much, all of you. Dr. Rebecca Richards-Cordum, Sunita Singh, Saad Bamla, and Sylvia Figuera, thank you very much. It was stimulating, it was fascinating, inspiring, all these things, and keep up the great work. We're going to throw it back to Maria Argos, and she'll wrap up for us. Thank you all.
Thank you.
Thanks, Jerome, and a
Thank
sincere
you.
thank you to our fantastic speakers, our moderator, and all our attendees for joining us today. As you sign off from the meeting, I wanted to let you know that you'll be asked to provide feedback about the conference. We really value your thoughts, so please take a minute to share any comments that you may have for us. For those that are interested in learning more about the sponsor institutions, you can stay on to view our slideshow for more information. And we look forward to having you all join us again next year. So take care and thank you, everyone.
Thank you.
Very much. Thank you.
Thank you.